Thank you, Jill. This is getting more and more layers like an onion.
Well, that's what I hoped. I didn't want to come all this way and, not be provocative.
But let me spend a few minutes before we do have lunch opening up Tina's comments for questions. So committee first.
Tina's coming back. Just me, okay.
I'm sorry? Sure. Janice suggested we open it up to everyone who spoke this morning. So let's do that, Janice.
Great. Thank you so much, Jill. Indeed, a provocative response to evidence. Thank you. I have a question. I also have an interest. I'm just going to headline my interest. I am looking for a way to focus the suggestions to us. I think since the opening of this, there have been a lot of rich discussions, rich suggestions, and so my interest is of focus. My question actually goes out to all of the speakers, particularly Jill, particularly Maddie, is around challenges. So Maddie, I appreciated your presentation on the 1972 IOM report, and the highlight that we are still where we were back then. You had a slide on challenges that prevented us from progressing and still being where we are today. Love Scott's question on have we improved at all in that time frame. And so my question is, which I think could help us focus, is what do you see to be the main challenges that are going to keep us from trying to figure out the mechanisms for change?
Oh, it's on. I thought it was. I was pressing it. So in Australia, where I've been doing a lot of work in this area, I have to say the challenges in Australia is the health system hierarchy. And when I talk about, who's in charge of the evidence, in Australia, there are a lot of challenges to change because of my own profession. And I think that some of that may also be happening here, but I don't like to speak as an outsider on that. But I think there are challenges that are very subtle that we're not aware of sometimes, and I think there are people who don't want to change.
And spread that to everyone, Maddie. How about your thoughts on that?
I think what I tried to emphasize in the talk was reinforced in much more detail in some of the later presentations. But for me, in terms of thinking about the committee's work, it's a challenge that moves beyond what is comfortable for us. So RCTs have come up over and over as a comfortable or trusted way of moving forward, but it leaves out a lot of other aspects of evidence that have been addressed, methods, educational methods that we feel secure in, assessment approaches. So it's thinking out of the box that I think is the big challenge for the committee. This is a looking forward exercise. Where do we need to go from where we are? And it isn't the comfortable answers that are going to move us forward.
I think the biggest challenge that I found in reviewing all that literature is just to really discern patterns. I think that whether you use an RCT or you use a CBA or you use an ethnographic study, I think that given the kind of expertise around the table, certainly probably not in the next 24 hours that you've been given, but with the expertise that you have, I think there are patterns that are starting to emerge about things that are potentially most effective, and that a mixed methods approach where you've got a high quality intervention where you're following it over a long period of time, and where you have skilled researchers that can do the ethnographic work, that can do the quantitative work, that can bring all of that to bear to what's been done so far and what's emerging, to look for patterns. I think they're there, and I think that's part of what the realist approach is, and that's not my area of expertise, but you're starting to look at what really is working and begin to see patterns instead of saying we're going to start with this and we're going to end with this. I think that's going to be something that'll be useful in the long run.
Other questions from the committee?
have one.
Barbara?
Tina, you hit the nail on the head when you introduced the concept that our audience and the expectation of physicians particularly is the biomedical model of research. And my new VP for health sciences at the University of Minnesota is a huge NIH researcher. This is exactly the kinds of questions he asks me. So at the end of the day, yes, we need to have these newer models, newer thinking in the future. What's the message to help bring people along who are in that model, that newer models of research, and particularly to this topic area, need to be deployed? So what's the memos? And again, thinking of Hugh's asking us to be simpler in our language and communicate well. So how do we do that? I know. That's my job every day. Goodbye.
Really looking for an answer, or is that more of a rhetorical?
I think this is a big issue. So
Yeah, I
I
do too.
think, and Scott knows this, when people see the reviews, at the Cochrane reviews, who are in a position to make recommendations or change, let's say, an accreditation agency, leaders in higher education, at the end of the day, this is the research model that they're used to. So I think it's not just, recommending new models. I think it is, how do we bring people along that these new models are needed to really get us to a different place?
I'm going to just take a very general shot at that, if I could. And what it makes me think of, when you said a new VP, we have a new VP too. And the real pressure is on that person to, whatever it takes, make change and make change in a 90-day format. And so maybe the way to make people listen is to not be quite so concerned. I mean, I think the research needs to keep going. But I think that we also need to just start implementing really comprehensive practice changes that include team-based care and be able to show that they're saving money and they're having patient outcomes. And then we can, as a science, we can continue doing what we're doing. But I think we need to just be really bold and not wait to start implementing some really, and people are doing that, I'm not saying everybody's waiting, but to be really robust in what we're willing to implement and then do the science in parallel, not necessarily everything we're doing having to have a strong research model. I mean, I have learned never to use the word research when I'm talking to my clinical colleagues because they immediately click that into it's going to take a really long time, it's going to be exclusive rather than inclusive. Nobody knows whether it's really going to make a difference until 10 years from now. But if I talk about quality improvement, everybody's on board. Now, I know those are loaded terms, but at least the concept of initiating real change and studying at the same time, I think, is the only way I'm going to appeal to my colleagues.
He has it first.
Yep,
And then
it's fine, Malcolm. I just urge you generally to just push the boundary of new research models in your work because it's in the way everywhere of delivering quality care in the time of mainly chronic diseases. It's a big deal. So push that. And I don't know if there are coalitions that need to be pushing it, but really it's a big problem. When we're talking about context, and that was great stuff, I just urge, particularly with changing in our looking at the perverse incentives and better incentives for our healthcare system under the triple aim, to directly be paying attention in the studies about where we know it, what was the model in that place, in that culture of payment or delivery, and where are you? Is it inside of an ACO? Is it inside of a staff model? operation? Is it inside of a single payer operation? I think paying direct attention to what kind of outcomes may be associated with what kind of incentive structures around payment might deliver some interesting information to us as we go along here.
So first, thank you so much for a very stimulating morning. I was just sitting there saying, I don't know if I want to be part of this committee. It's a very, very complex, and you have a really big job. But you are very capable of delivering, so I'm glad that you are on it. I was beginning, and I really appreciate, Jill, what you have brought up to really the caveats and what we need to think about, because I was sitting there worrying that we are going to take something that's very complex, that's very robust, that has theories in it, that has process in it, and reduce it to variables and reduce it to operations, that we're going to lose the process and we're going to lose the content. So there is really three parts there. There is content, and there is a process, and there is an outcome. And there is a culture. And you can take a culture that's very autocratic culture, that's a hierarchical culture, and then you have just a small group of people who are teaching IPE in it, and then want to look at the outcome of that. So it's more than a context. It's really a culture of values and beliefs, and we must not lose that. So we can't reduce it to those experiments and lose track of how you create an environment. So I guess a question to you, have you in your review seen research that addressed the culture and environment in relationship to some outcomes rather than just the intervention itself? So that's a question that could help this group, but that's also a plea to this committee not to become reductionist in something that's really important. We tried to do that with clinical judgment, and it did not work very well.
Maddie?
I think that's a key to the point that I made in terms of challenges at the end, that even under the best of circumstances, what are the limits associated with strictly IPE efforts in very complex environments, both on the education and the practice side?
Well, we've tried to deal with both some reductionist issues as well as some more holistic approaches and different methodologies of evaluation assessment. And I suspect that will be on the committee's mind as we go to lunch in the next 3 days when they lock us in some room here. A final question.
Final comment, Mary Barger, American College of Nurse Midwives, is that PCORI is struggling with these same concepts and the same complexity of patient-centered care. And so I think we need to look at what they're looking at, like propensity scoring and regression discontinuity designs, and including the qualitative, because I think they have some money to put into the methodological issues, which they have been doing. And so to really look at what their experience is and examining what works in one subgroup than the other, which is what we've sort of been talking about, is culture, what Afaf was just talking about, an effect modifier. And if so, that's a really important thing to know. How does it modify the effect? So I think, let's use some of the stuff that PCORI's paying people to do methodologically that may be applicable to what we're trying to do.
The idea of targeting individuals who might pay for what we want to do. Maddie, you're going to close the morning session.
I just want to say that all of these things are moving targets. And when we use the language of patient-centered, which has been with us for a long time, that is a moving target because we are now learning what it means to have patients, families, and communities as true partners in care and not just be centered in the old ways we've thought about this. A lot of us claim that we've been patient-centered for a long time, but I think that's very different than the new models that are emerging of partnership.
So we can move from, I'm sorry, Jill, please.
Another thing about language is this pervasive idea at the moment of the patient at the centre of the team. And what does that mean? Does that mean every team is formed again around a new patient? And it's another almost meaningless phrase if we want to look at what it means, I think. But it's out there now, and it's a marker of quality. And I think we really need to think what that actually is pointing to.
So perhaps we can move from centeredness to partnership to patient-driven. That is, aligning what we do educationally and in practice with what the public's expectations and needs are. So one can have this kind of conversation around language endlessly. But let me thank the group for some very provocative comments and thoughts. And we'll reconvene for the afternoon session at 1:30, and we still have more treats to come.